Thank you. Hi, good morning to all the faculty members and delegates for this wonderful meeting. My name is Rahul Pathak. I am working as a senior medical advisor for Panacea Biotech. And on behalf of Panacea Biotech, we are very grateful to Mumbai Hematological Group for giving us this wonderful academic opportunity to partner with this important meeting. So it's a Sunday morning. I will not take much time. I just would like to introduce Panisha Biotech as a company. We are actually into two businesses. Pharmaceuticals. If I talk about vaccines, we are the fourth largest company in India currently, and we are the one of the first manufacturer of Sputnik V in India. Along with the Sputnik V, we are having different vaccines like hexavalent vaccine, which is one of the first kind of its vaccine. And we are also working on several new vaccines for COVID, dengue, pneumococcal. If I talk about pharmaceutical, we are innovator of many drugs, along with specifically for the oncology. We are having the first generic version of Abraxane with the brand name Pacliol. So now we have already spent 10 years with Pacliol, and Pacliol is not only using in India, we are also exporting Pacliol in different parts of the world. We are having all the in vivo, in vitro, and also human studies on Pacliol in comparison to Abraxane, which shows, very good bioequivalence with the Abraxane. Along with this medical oncology, we have a distinct portfolio for the hemato-oncology also. So this is a brief introduction regarding Panisha Biotech. And once again, thank you very much for giving us this opportunity, Dr. Agrawal. And so now I would like to request Dr. Agrawal to start the meeting. Thank you very much.
Thank you, Dr. Rahul, for that introductory remarks. I'll just share my screen. So good morning to one and all. Today, our guest speaker is Dr. Marco Capicchi from Milano, Italy. He's going to lecture on intricacies in managing thrombotic thrombocytopenic purpura. This webinar is brought to you by Mumbai Hematology Group, supported by Panacea Biotech, managed by Mice Ideas. Next weekend, we have 3 webinars. Friday, 4th March, 7 p.m. onwards, we have MD Anderson Symposium on Myelofibrosis, Advances Management of in 2022. We have 2 speakers, Dr. Prithviraj Bose speaking on the medical aspect, and Dr. Uday Popat speaking on the transplant aspect. Saturday, again 7 p.m. onwards, we have Cardiovascular Fitness in Sickle Cell Disease by Dr. Joy Ogunsile from USA. And then on Sunday morning, 11:30 a.m., we have Dr. Neeraj Arora from Ahmedabad speaking to us on NGS in leukemia. Our discussants today are some very important personalities in the field of hematology from India. Dr. Chandrakala S. from KM Hospital, Mumbai. Brigadier Dr. Sanjeevan Sharma from Command Hospital, Lucknow. Dr. Satish Kumar A. from Manipal Hospital, Yashwantapur, Bangalore. Dr. Riya Balika from Wokad Hospitals, Nagpur. Dr. Karuna Kumar K. from Yashoda Hospital, Sikandarabad. Dr. Abhishek Dutatra from HCG Cancer Center, Ahmedabad. Dr. Amrita Chakrabarti from Max Hospital, Delhi. Dr. Aditi Jain from Safdarjung Hospital, New Delhi. Dr. Pooja Prasad from VMMC and Safdarjung Hospital, New Delhi. Dr. Akshaya Mandolay from TMC, Kolkata. Dr. Gunjan Prasad from Apollo Hospital, Kolkata. Dr. Dibya Jyoti Prusti from SCB Medical College, Cuttack. Dr. Mona Vijayan from All India Institute of Medical Science, New Delhi. Dr. Reema Ibrahim from AIMS, New Delhi. Now we come to the Sunday quiz for the students and others. Today's quiz is related to diagnosis of etiology of a febrile illness by bone marrow biopsy. We will give you clinical profile and show you a bone marrow biopsy which was diagnostic. You have to pick up the diagnosis and email this diagnosis to mbagarwal1@gmail.com. And as usual, fastest finger first will be the winner, and we'll tell you names of all those who forward the correct diagnosis. So this is a case profile. A 13-year-old boy, a known case of Postman syndrome, got admitted for persistent fever, headache, acute confusion, breathlessness, and cough. After CSF examination, neurologist diagnosed him as meningoencephalitis. He developed rapidly worsening type 2 respiratory failure. The imaging showed extensive multifocal areas of pulmonary consolidation. He was treated with GCSF, meropenem, colistin, vancomycin, micafungin. He developed severe thrombocytopenia with platelet count going down to 7,000, requiring platelet support with poor increments. A bone marrow aspiration biopsy was done mainly to find out the mechanism of thrombocytopenia. However, in the bargain, we got a diagnosis with respect to the etiology of his febrile illness. That's the bone marrow. Keep it on for a while because you have to pick up the diagnosis of etiology of fever from this. That's a special stain on the bone marrow. You can see two pictures side by side. Right. So what did the marrow show? That diagnose the etiology of this febrile illness. Email your diagnosis to mbagarwal1@gmail.com. The second part of this morning is the case of the week. And we are going to discuss a miracle drug. The drug is well known to you, but in this patient, it worked like a miracle. 36-year-old man, strong history of alcohol for last 8 years. Got admitted with marked ascites and hepatosplenomegaly in the GI department. The LFT was deranged. Hep B, Hep C were negative. Chest film was normal. Imaging of the abdomen, sonography, fibroscan, and Doppler showed that he has a fatty liver with fibrosis. There was portal vein thrombosis. The collaterals are the splenic hilum. Chest CT didn't give any additional information. Ascitic fluid examination, besides neutrophils, lymphocytes, and red cells, showed normoblasts, granulocyte precursors, and occasional megakaryocytes. Alpha-fetoprotein, carcinoembryonic antigen, and CA19.9 were normal. So we have a 36-year-old man, alcoholic, admitted with ascites, liver, spleen, and then ascitic fluid shows you this. His blood counts, hemoglobin 8.8, white cell 12,900, platelet 702,000. There's a mild leukoerythroblastic reaction with 13 nucleated RBCs. One doubtful blast was also seen in the peripheral blood film. Bone marrow aspirate was dry and the biopsy showed collagen fibrosis. Myelofibrosis was suspected, either primary or secondary. BCR-ABL1 and JAK2, V617 of mutation by PCR were negative. A diagnostic procedure was performed, and that was liver biopsy. Liver biopsy showed marked extramedullary hematopoiesis filling the sinusoids. The liver lobe itself was not involved, and there was no evidence of tuberculosis, lymphoma, or metastasis. You can see sinusoids packed with extramedullary hematopoietic foci. You can appreciate the megakaryocytes and other cells. Immunofluorescence showed distended sinusoids showing trilineage proliferation. What you see in the red is the erythroid precursors, and what you see in the green are the megakaryocytes. NGS panel report came in and it showed MPL mutation. Diagnosis of primary myelofibrosis with intrahepatic and peritoneal extramedullary hematopoiesis was made. It was started on ruxolitinib, that is Jakavi 20 milligram twice a day. 3 weeks later, his ascites completely dissolved. His weight dropped from 60 kg to 48 kg because of loss of all the water that he had accumulated. 6 months later now, he has got no enlarged liver and spleen. 12 months later, he's in a good control and asymptomatic. So that's a miraculous effect of JAK2 inhibitor in a case of MPL positive primary myelofibrosis with extramedullary hematopoiesis affecting hepatic sinusoids and the peritoneum, producing massive ascites and hepatomegaly. So final diagnosis was extramedullary hematopoiesis involving liver and the peritoneum in a case of MPL positive primary myelofibrosis with extraordinary response to ruxolitinib. That was the case of the week. And now it's my privilege to introduce our chief guest of the day, who is going to inaugurate our webinar and address us. I'm proudly privileged by the presence of a very senior personality in the field of pediatrics and hematology, Professor Dr. Jagdish Chandra from New Delhi. It doesn't require an introduction, and I'm completing the formalities. Professor of Pediatrics, Postgraduate Institute of Medical Sciences and Research, and ESIC Model Hospital, New Delhi. He worked at LHMC from 1987 to 2020, and he was director of LHMC from March 2016 to October 2017. He's chairperson of Hemoglobinopathy and Other Red Cell Disorders Subcommittee of Pediatric Hemato-Oncology chapter. He was chairperson for the Hodgkin Lymphoma Study Group of INPOC. He received Shri R.V. Lokeshwar Oration Award of PHO chapter of IAP 8 years ago, 2014. He is a member of the expert group of Ministry of Health and Family Welfare for guidelines for prevention management of hemoglobinopathies, and also a member of the expert group for guidelines on disability certification of hemophilia, sickle cell disease, and thalassemia. A prolific publisher, has published over 200 papers and chapters in the books. We are grateful to him for having spared his time and agreeing to inaugurate our today's webinar and address us with the words of wisdom. Over to Professor.
Thank you, Professor Agarwal. Thank you, really. Thank you very much for those kind words of introduction, and also giving me opportunity to be part of this webinar. I'm really humbled by those words, and also giving me the honor to be the chief guest of this webinar to inaugurate this. Well, friends, as we all know that there are tremendous advances in the field of hematology over the last 2 to 3 decades. There are improvements in the diagnostics. Obviously, the therapeutics also have improved. There are advancement in the understanding of diseases, their pathogenesis, and that has made the subject of hematology, which was always a fascinating subject, and it has become more and more fascinating. And obviously, with better understanding of pathogenesis, the therapeutic options, including monoclonal antibodies and targeted therapies, they are emerging, even for those diseases which otherwise had a poor outcome. And this case which Dr. Agarwal showed just a minute back, this is an example of that, how the things have improved in the field of hematology and how fascinating the subject has become now. And importantly, these advances are not only limited to the more advanced countries. They are now in India and other countries of this region as well. We are seeing significant developments. In fact, in the field of hematology, we see there are increased opportunities for training of the young doctors. There are 7, 8 centers which offer the DM hematology, DM hemato-oncology, and there are several other centers who offer the DNB in the field of hematology as well as pediatric hematology. In the public sector also, hemoglobinopathy and hemophilia care centers at the district level are being set up. However, for a country as vast as ours, there is a need to have more trained personnel to provide focused care to patients with wide variety of hematological disorders. And let us hope in times to come, more and more of young doctors will join this fascinating field of hematology. So with these few words, I hand over to Professor Agarwal to introduce the speaker for this fascinating subject of TTP. Thank you, sir.
Thank you very much, Professor, for those kind words and sparing your time to inaugurate this webinar this morning. I'm grateful to you. I'll now share my screen to introduce our guest speaker for the day. And as you know, our speaker today is Dr. Marco Capecchi from Milano, Italy. He has been our speaker last year, and we had such a tremendous demand to listen to him, and many of our students and faculty from this part of the world missed listening to him. We requested him to come back as a speaker, and he has obliged us. Today we have 17 countries who have registered, delegates from 17 countries and students and trainees from 17 countries who have registered for this webinar. To complete the formalities of once again introducing him, he received his degree in medicine and surgery at the University of Pisa and at Sant'Anna School of Advanced Studies, Pisa. He received his postgraduate degree in hematology at the University of Milano. He works with Professor Flora Tevendi, who has also been our regular speaker, both in person and through online, at the Angelo Bianchi Bonomi Hemophilia and Thrombosis Center, Milano, Italy. He is a specialist in the field of hemostasis with specific interest in venous thrombosis and platelet disorders. He conducts his clinical and laboratory research activity in the field of coagulation disorders with a focus on hypercoagulation. Today, he's going to lecture on intricacies in managing thrombotic thrombocytopenic purpura. Thank you so much, and over to him.
Hi, good morning, everybody, and thank you again for this invitation, Professor Agarwal. It's a pleasure to be with you again today. And I will try to share my screen, first of all. Can you see my screen?
Yes.
Okay, great. So, we have already discussed about thrombotic thrombocytopenic purpura in last August, if I remember well. And today I would like to talk about, again, this rare disease and a very challenging disease to diagnose and treat. And because last time many of the questions were focused on the diagnostic management of the disease, I will try to spend more time on this part today. So, thrombotic thrombocytopenic purpura is a thrombotic microangiopathy, and all thrombotic microangiopathies are characterized by these three features. Thrombotic microangiopathies are due to the formation of thrombus of small clots in the small vessels, and these lead to a widespread ischemic damage that involve many different organs, especially the brain, the heart, the kidneys, but also all the other organs. And the formation of these small clots in the blood vessels lead to the reduction of the platelet count due to the trapping of these platelets in these vessels. And imagine the presence of small clots in these small vessels and the blood that still flows in these vessels. All the red blood cells will be blocked in these clots and will go through a process of fragmentation. So another feature, another key feature of the disease is represented by a hemolytic anemia that we call microangiopathic hemolytic anemia. So thrombotic microangiopathies are a wide spectrum of diseases, and you can see here how many kind of diseases we are facing too. And I would like to spend just few words for some of them, and especially to the complement-mediated TMA, which were called in the past hemolytic uremic syndrome. And we distinguish two kinds of complement-mediated TMA, which are the acquired one and the hereditary one. They are due to the defect in some proteins that are involved in the alternative pathway of the complement system. And while in the hereditary form we have a congenital defect of some of these proteins, such as factor H or factor I, in the acquired form we have autoantibodies that are directed against these proteins. We should remember also the drug-mediated TMA, and the drugs that are more involved, that are represented by oral contraceptive, by quinine, which is an antimalaric drug, by some antiplatelet drugs like the thienopyridine, clopidogrel, but also some immunosuppressants like cyclosporine A or tacrolimus. We should remember also the other form of hemolytic uremic syndrome, which is the classical one, and that is caused mainly by some toxins that are released by some kind of bacteria, especially Escherichia coli bacteria. But between all these kind of TMAs, we will talk about TTP, which is the thrombotic thrombocytopenic purpura, and it's very important to distinguish this kind of disease in the field of all the other TMAs, because it deserves a specific treatment. So here you can see the clinical features of the TTP. TTP is characterized by thrombocytopenia, microangiopathic hemolytic anemia, but also by neurological signs. Patients can have weak neurological signs, but this neurological involvement can be also very severe, leading to coma. The renal impairment is usually not that severe, and fever is not always present, but this is the classical penta that was described years ago. TTP is a rare disease. The incidence is from 5 to 11 cases per million people here, and it is a disease that affects mainly the females in their childbearing age. So the peak of incidence is around the third, fourth decades of life, and the mortality is very high if not diagnosed properly and treated well. So the mortality is around 90%. But if the disease is diagnosed properly and very quickly and treated properly, this mortality rate reduces to 10 to 20%. However, in the acquired form of TTP, the risk of recurrence is still high, and around 1/3 of patients will relapse. Let's look to the physiopathology of TTP, and as you can see here, Adams-13 is the most important protein involved in the disease. Usually in the small vessels, we have high molecular weight multimers of von Willebrand factor, which is a key protein in the pathogenesis of the disease. In fact, these high molecular weight von Willebrand factor multimers that are adherent to the endothelial surface are usually cut by Adams-13 in small pieces, in small peptides. But if Adams-13 is not present because its production is reduced, or because some antibodies are directed against this protein, making it not work well, these multimers will be present in the small vessels and will represent a scaffold to trap the platelets and red blood cells, initiating the formation of the clots in the small vessels. Adams-13 so is a key protein in this disease, and it is a metalloprotease, very big one, and it is synthesized by hepatic stellate cells, but also by endothelial cells and platelets, and its half-life is about around 2 to 3 days. It is produced in an activated form, so it doesn't require activation, and no natural inhibitors does exist in the plasma. Adams 13 cleaves the von Willebrand factor multimers at the A2 domain. Let's look at this picture, which is very explicative of the process. In condition of absence of shear stress, so in the big vessels of our body, the von Willebrand factor exists in this globular form. But when the shear stress increase going from the big vessels to the small vessels, you can see that the von Willebrand factor expands, and from the globular form, it reaches an extended chain form in the small vessels. In this way, the A2 domain, which is normally folded in the globular form, becomes available for Adams 13. And therefore, Adams 13 can start to cut the von Willebrand factor multimers in small peptides. Normal levels of Adams 13 are higher than 40, depending on the different tests, and a severe deficiency of Adams 13 under 10% is diagnostic for TTP. However, mild to moderate Adams 13 deficiency is not specific for TTP and can be found in all the other types of TMAs. So Adams 13 deficiency is the mainstay of TTP, and we should distinguish two forms of TTP: the acquired form, which is the more prevalent, and it is characterized by the presence of anti-Adams 13 antibodies, while the congenital form, which is very rare, around 5% of cases are congenital, is characterized by the absence of antibodies, but by the absence of the production of Adams 13. So we have seen that the mortality rate of acute phase of TTP is really high, so a proper and a quick diagnosis is very important. Unfortunately, the Adams 13 test is not widely available in different labs, so it's very important, and usually it's very difficult to have this result in a few hours, because we should take in mind that treatment should be started at least within 24 hours after diagnosis. So to try to understand, to predict the presence of a severe deficiency of Adams 13, some clinical pretest score have been proposed, and I will show you the most two important one, which are the plasmic score and the French score, and this would help the clinicians to predict the presence of a severe deficiency of Adams 13. So the plasmic score consider take into account these different variables. So the presence of a platelet, and each variable that is present gives to the score 1 point. So if you have a patient with a platelet count of less than 30,000, a serum creatinine level less than 2 milligram deciliter, the presence of hemolysis as defined here, the absence of cancer in the previous year, and no history of solid organ or stem cell transplantation, the normal prothrombin time less than 1.5, and a mean cell volume of less than 90. If you take together all these variables, you obtain a score, and if the score is between 5 and 7, you will have a risk of having a severe deficiency of Adams 13, which is intermediate to high. And you can see that this score correlates well with the risk of having an Adams 13 levels less than 10%. There is also the French score that consider only these two variables, which are the platelet count and the serum creatinine, but take in mind that this score intrinsically consider all the other variables that are considered in the plasmic score. And even this score correlates well with the pretest probability of having a severe deficiency of Adams 13. So we have understood that Adams 13 testing is very important, and so let's look more in detail about this phase. And as for every laboratory test, pre-analytical variables are of pivotal importance. So you should remember that we need to collect plasma and also serum to evaluate the presence of antibodies in the acquired form. So the plasma should be collected in saturated tubes, of course not in EDTA anticoagulated plasma, because of the interference with the clotting test. With this saturated plasma sample, saturated tubes, we should obtain the platelet-poor plasma by centrifugation at more than 2000 G for 15 minutes. And the centrifugation to separate the plasma should occur as soon as possible. And after obtaining the plasma samples, we should store quickly these samples in liquid nitrogen and frozen and store these samples at below -40. In our lab, we store it in -80. If you need to send the samples to another lab to make the test, you should remember that you need to use dry ice for shipment, and repeated freezing thawing cycles should be avoided. So the blood collection should be also done before starting the treatment, because the mainstay of treatment, as we will see later, is represented by plasma exchange. So plasma of donors will be infused in the patients. So this donor plasma should interfere with Adams 13 dosage, but also with anti-Adams 13 antibodies dosage, because it may lead to a dilution of these antibodies. And I will have reported here, so it's very important to collect the plasma before the treatment start, but it's also true that if the patient has already done few number of plasma exchange, it's still possible to try to do a diagnosis with the Adams 13 testing. And I have reported here our experience on 18 patients with acute TTP, acquired acute TTP, and we have seen that if a patient has undergone at least 3 plasma exchange, still more than 75% of patients had showed a level of Adams 13 less than 10%. So at least 3 packs doesn't affect that much the test. So let's look about the assays that we can perform. I have distinguished 3 kinds of tests, so we can evaluate the activity of Adams 13, we can evaluate the antigen levels of Adams 13, and we can evaluate the anti-Adams 13 antibodies. Let's look more in detail all these kind of tests. So regarding the activity assays, this table is just to show you that many different assays have been proposed in the literature. But and all these tests can differ because some of them detect directly or indirectly the Adams 13 activity. They differ with the von Willebrand factor substrate, that can be the full length of Willebrand factor protein or some peptide that contain the A2 domain. Some tests have reagents that are used to denaturate or not, or that have the activator, and also the detection method can be different. And the most used are the FRET-based or the chromogenic ELISA-based tests. So let's look at the 2 most popular tests that are used to evaluate the activity of Adams 13, which are the FRET-based test and the chromogenic ELISA by Technoclone, which is called Technosyn. So regarding FRET, FRET is a test in which we use the von Willebrand factor 73 peptide, which contains the A2 domain. You can see that this peptide in the original form contains a fluorophore which emits some energy, and a quencher which is close to the fluorophore. So when these 2, the fluorophore and the quencher, are close to each other, the quencher absorbs the energy of the fluorophore. But so we don't have any emission at 440 nanometers. But when you add the plasma to the system, you can see that Adams 13 cut, if present, of course, will cut the von Willebrand factor peptide at the A2 domain, so that the quencher will be no more close to the fluorophore, and therefore the energy emitted by the fluorophore will not be absorbed by the quencher. So a detection system will detect the energy emitted by the fluorophore. And this energy will be directly associated to the presence of Adams 13 in the plasma of the patients. So going to the other test, which is the chromogenic ELISA test, the principle is the ELISA principle. We have a plate which is coated with monoclonal antibodies against the GST, which is conjugated with again with the von Willebrand factor 73 peptide. When you add the plasma of the patient, Adams 13, if present, will cut the von Willebrand factor peptide, and at this point, the site of the cleaved peptide will be recognized by the horseradish protease, peroxidase, and adding the substrate of HRP, we will have a color signal that we will detect, and it will be directly dependent on the presence of Adams 13. This table just compare the two methods, and I would like to highlight the fact that both methods are very time consuming. So from 2 to 4 hours are needed to have the result. And both of them need a spectrophotometer to detect the signal, and both of these methods are not automated. Here you can see that the two tests are correlate well, so there is a good agreement between the two tests, so they can be used equally. But these tests are have interference. So you should take in mind that bilirubin, hemoglobin, and lipemia can interfere with the results of this test. Let's look more in detail to bilirubin, which is the most important variable that interfere with the test. And as you can see here on the left panel, in which there is consideration about FRET test, you can see how with increasing levels of bilirubin, the apparent levels of Adams 13 is lower than expected. And these the levels of unconjugated bilirubins that affect the test are levels higher than 5.85 milligram deciliter, and this is due to fluorescence quenching. So unconjugated bilirubin acts like a quencher and reduces the basal fluorescence, so leading to an apparent reduced levels of Adams 13. If you look at the other test, the technozyme test, you can see that there is no effect of bilirubin at different levels of Adams 13 on Adams 13 test. And this is due to the fact that the different stages of washing that are intrinsic of the method wash away also bilirubin. So it's true that bilirubin is a variable that should be taken into account because it can affect the FRET test, but only when bilirubin is higher than 5.25. And if we think about the characteristic of the patients with acute TTP, we can see that in most time these patients doesn't present with very elevated levels of bilirubin. So it's true that bilirubin can interfere, but it's not very common to have patients with high levels of bilirubin in acute TTP. Also, hemoglobin can interfere, so hemolysis can interfere because hemoglobin can specifically bind to the A2 domain, so preventing cleavage by Adams 13. So we should take into account also that the amount of hemolysis can interfere. And also lipemia can interfere, but no data are available as for bilirubin for lipemia. So it's important to take into account these three variables when we interpret the Adams 13 activity assays results. Here in this slide, I would like to highlight the cons of these tests because, as I've shown before, the turnaround time is very long, from 2 to 4 hours, and the lab staff should be well trained. So these tests are available in few specialized hospitals, and because of this consideration, the test is not suitable for emergencies like TTP is. So in the last years, other Adams 13 activity assays has been set, and 2 of them are available, but I will not talk about this one because this is a semi-quantitative test, so it's not very suitable for managing patients properly. But the Hemosil Acustar Adams 13 activity assay is very important and will substitute the test that I showed before. So this is a quantitative test. It's a chemiluminescent immunoassay. I will show you better how it works. And it is an automated test, which is very important because it reduces the time, the running time of the test. And you need to have this instrument, which is the ACL Acustar, which is, as all of this instrument, is very expensive. But the positive consideration is that this instrument can be used also for other assays at the same time, such as coagulation assays, autoimmunity assays. So it could be used in a lab for many different purposes, and also for Adams 13 activity test. So in this slide, we will see how these tests work. And basically, we have some beads that are coated with monoclonal antibodies, and these monoclonal antibodies are conjugated with GST linked to the von Willebrand factor 73 peptide. When you add to the system the plasma of the patients, Adams 13, if present, will cut some of these von Willebrand factor peptides and will expose a site that can be linked by the monoclonal antibodies that are targeted to this specific site, which is produced by Adams 13 cut, and these monoclonal antibodies are labeled with isoluminol, so we will detect the luminescence signal, which will be directly dependent on Adams 13 presence in the patient plasma. So here you can see the agreement between this test and the other 2, the FRET and the Technozyme, and you can see the full agreement between the 2 tests. And here the advantages of this test against the other 2. So the running time is only 33 minutes, so it's suitable for emergency setting like TTP is, and it is a fully automated method compared to the other 2, so it can be used very easily in many different labs and not only in specialized labs. Here you can see also another important point, and that all the variables that we have discussed before, so bilirubin, hemoglobin, lipid, but also the rheumatoid factor doesn't interfere with this test. So after we have discussed so far the assays that are used to detect Adams 13 activities, let's move to Adams 13 antigen very quickly. Adams 13 antigen is not necessary to evaluate the plasma levels of the antigen in the emergency setting, but can be useful when you need to discriminate acquired from congenital TTP. And this is just an ELISA-based assay, so I will not go further in detail. And I just want to highlight that the antigen levels can be detected if you suspect a congenital TTP before performing the genetic testing. So let's move to the anti-Adams 13 antibodies tests, and there are two different kind of tests that we can perform. We can detect in the plasma the levels of the IgG anti-Adams 13, and we can do that with just an ELISA-based method. But we can also evaluate the inhibitor effect of anti-Adams 13 antibody. And to do that, we use a Bethesda-like mixing assay, which is derived from the Bethesda assay used for detecting anti-effector rate antibodies in acquired hemophilia A. So as conclusions of this part of the presentation, Adams 13 activity testing is very important to confirm the TTP diagnosis. It should be done in emergency, so very quickly. And unfortunately, the currently available Adams 13 activity assays are not available in every lab. So the need for easier assays with turnaround times that are more quick are needed, and nowadays we have one more test that will become available in the future in many labs. And because of the many different tests that we have and because of the variables that can affect these tests, it's very important a crosstalk between the clinician and the laboratory staff to avoid the misinterpretation, but also over testing, because it's an important point, because these tests are in specialized hospital are requested maybe more often than needed. So Adams 13 testing is the first is the first step to perfectly manage a patient with TTP. So now we can move to TTP treatment, and the first point that you should consider when you have made a diagnosis of TTP is that this patient should undergo a plasma exchange. To perform plasma exchange properly, you need a central venous catheter. So the first step in management, in therapeutic management of these patients, is to place a central venous catheter. The central venous catheter should be placed by an experienced operator, possibly under ultrasound guidance, because these patients present very often with very low platelet count, usually less than 10,000, so the risk of bleeding is very high. And also the site of the placement of the CVC should be carefully chosen. So we prefer not to choose the internal jugular vein on the subclavian vein, because these are sites that are associated with a higher risk of bleeding. So the femoral vein is preferred in this setting. And it is also very important to remember that platelet transfusions should be avoided before placing the CVC, because despite the very severe thrombocytopenia that these patients present, ischemia is a greater risk than bleeding. And I will show you just to highlight this point, that some case reports have reported the occurrence of fatal myocardial infarction or neurological complications after platelet transfusion for CVC placement. So remember not to transfuse platelets before CVC placement. Looking at treatment, we should consider the different form of TTP. In the congenital form, you don't have Adams 13 production, so you need to replace a functional Adams 13, and to do that, we infuse fresh frozen plasma. In the acquired form, the replacement of Adams 13 is not sufficient. You need to remove also anti-Adams 13 antibodies, and you need also to downregulate the immune system activation. So in the congenital form, we give patient fresh frozen plasma at this dosage, 15 to 20 milliliters per kilo every day in the acute phase. While in the remission phase, in selected cases, we can consider to give plasma every 2 to 4 weeks. While in the acquired form, in the acute phase, the mainstay of treatment is represented by plasma exchange and immunosuppressors, which are represented by steroids in the acute phase, while in the remission phase, only in selected cases, we can go on with the immunosuppressors. This slide just to tell that in the next future, in congenital TTP, we will have another treatment that can be used, and will be the recombinant Adams 13, and nowadays clinical trials are ongoing on that. For the acquired form, the mainstay of treatment on the acute phase is plasma exchange together with steroids, but also other treatment are nowadays used, especially cafazizumab, and also other drugs can be taken into account in specific cases that don't respond to the standard treatment. So let's look at plasma exchange that has changed completely the outcome of these patients. So with plasma exchange, the mortality goes down from 90% to 10%. And in this slide, I want to highlight that plasma infusion is not the gold standard, because plasma infusion only gives ADAMS 13 but doesn't allow us to remove the anti-ADAMS 13 antibodies. So the plasma exchange, and not only plasma infusion, is the gold standard of treatment and is associated with a higher rate of survival. So plasma exchange should be started within 24 hours after symptoms onset, and you don't need to wait for ADAMS 13 activity test results, but when you suspect with the plasmic or the French score in acute TTP, you take the specimen, you send it to the lab, and you start immediately the plasma exchange, waiting for the results of ADAMS 13 levels. So at least one daily plasma volume should be exchanged, and in some severe cases, we can exchange 1.5 plasma volume for the first 2 to 3 days. And plasma exchange should go ahead for many days till the platelet count is higher than 150,000 for at least 2 consecutive days. And the LDH should be normalized and clinical symptoms should be recovered. In some cases, when we can consider not to stop immediately the PECs when we reach this objective, but we can consider to taper the plasma exchange, and this may reduce exacerbation. You can see here that plasma exchange can be associated with different complications, especially reaction to plasma infusion, but also paresthesia, because remember that during plasma exchange, a very careful should be taken for the electrolytes such as potassium and calcium, because some of the anticoagulants that are used during the procedure can reduce the plasma levels of these electrolytes. So to get plasma exchange, corticosteroids should be started, and we use prednisone at this dose, 1 milligram per kilo every day. We should go ahead with steroids for at least 3 weeks, and the tapering should be done very slowly during 4 to 8 weeks after remission. In severe cases, intravenous methylprednisolone should be considered for the first 3 days. Patients that doesn't respond to plasma exchange after a total of 7 plasma exchange with still elevation of LDH are defined to have a refractory TTP. And in this setting, what can we do? We can consider to intensificate the plasma exchange every 12 hours or double the plasma volume that we exchange, or we can consider some rescue therapy. And nowadays, the treatment of choice is represented by rituximab. Rituximab is, as you well know, a monoclonal antibody directed against CD20 on B lymphocytes, and it can be used in refractory TTP, but also in patients that have an exacerbation. And exacerbation is defined as a relapse of TTP that occur within 30 days after platelet normalization. And rituximab can also be used in the chronic phase when a patient relapses. Rituximab used at the standard dose of 375 milligram per square meter every week for 4 weeks. We can go ahead to 6 weeks if the response is not sufficient. And when you use rituximab in the acute phase, you should remember that the plasma exchange can remove the rituximab, that part of the rituximab that you infuse in the patient, so that remember to do the rituximab after the daily packs, and at least and don't start the next packs 4 hours before the end of rituximab. So in the acute patients that have been treated well and recover after the acute phase may go to exacerbation, and the mortality rate, despite the standard treatment with PECs and steroids, still is around 10%. So what can we do for this patient to reduce further the mortality? We should stratify the risk of these patients, evaluating at diagnosis the cardiac involvement and the neurological involvement, first of all, because nowadays we have another drug, which is caplacizumab, that can be used in the acute phase. So it's very important to stratify patients on their risk to decide if we need to use caplacizumab or not in these patients. And there are also other therapies that can be taken into account, and I mean the recombinant avastatin, even if not available yet, but it will be in the next future. But let's consider the caplacizumab that has been studied in phase 2 and phase 3 study in 2016 and 2019. Caplacizumab is a nanobody directed against von Willebrand factor, and it binds to the A1 domain in von Willebrand factor. You can see here how it works. In TTP patients, you can see that the von Willebrand factor multimers with their A1 domain binds to the GP1B protein on the surface of the platelets. And this leads to the clot formation in the small vessels. With caplacizumab, caplacizumab will bind this A1 domain on the von Willebrand factor, preventing their link to the GP1B proteins on the platelet surface, and therefore preventing the clot formation in the blood vessel. So this is not a therapy of a pathophysiological therapy of the disease, but it's very important to avoid the clot formation in the blood, in the small vessels, and therefore the diffuse ischemia of different organs, while the treatment of the disease works waiting for a remission. So here you can see the design of these two trials. They were both, they had both two arms. One arm with both of these arms had the standard treatment, and in one arm we have caplacizumab, and in the other arm placebo. Let's go to the results of these trials. You can see here that the number of days that with caplacizumab, the number of days to have a platelet normalization is lower than in placebo, in the placebo arm. And so the most important outcome of these two trials is that the time to response was significantly reduced with caplacizumab compared to placebo. And you can see here that the volume of plasma, or the volume of the plasma that has been used in caplacizumab patients is lower than in the placebo group. The number of days that the patients spent in the intensive care unit and in the hospital were lower with caplacizumab compared to placebo. And also the rate of complete remission is high with caplacizumab, the exacerbation rate is lower, and also the number of deaths is lower. Coming to the safety of the drug, we can see how bleeding events are higher with the caplacizumab, but grade 3 and 4 bleeding events are comparable to the placebo. And in this slide, you can see how, again, with caplacizumab, they're refractory to treatment, so exacerbation are lower than in placebo. And another feature of the acute TTP is represented by thromboembolic event, especially at the site of CVC placement. And you can see that with caplacizumab, the rate of thromboembolic event is lower than with placebo. So after treatment of the acute phase, the patient hopefully go into remission phase. And which are the different approach in the congenital and the acquired form? In the congenital form of TTP, if a patient represents many different acute phases during his life, we can consider prophylaxis with plasma infusion at regular intervals, usually 2 to 4 weeks, but we tailor this schedule on the single patient. While for the acquired TTP, we should consider that which is the risk of recurrence. The risk of recurrence is high. Around 1/3 of patients will relapse, and this relapse occur usually in the first 2 years after acute TTP onset. And which are the risk factors for recurrence? First of all, low levels of ADAMTS13 in remission phase. So patients with the persistent low levels of ADAMTS13 in the remission phase are at higher risk of relapse, but also some triggers such as infection, surgery, some drugs, or especially pregnancy can represent risk factors for recurrence. And you can see here in this slide how with the reduction of ADAMTS13 levels, the probability of relapse increases. So patients with that are at high risk of relapse should be treated preventively with rituximab, and rituximab nowadays is the mainstay of treatment of patients to prevent relapse, even if other immunosuppressive therapies such as cyclosporine and azathioprine are considered. In this slide, which is my last slide, I would like to recap very quickly the presentation and talk about the future perspective. So regarding diagnosis, it is very important nowadays to do a more rapid and diagnosis, and to do that it's important to have tests that allow us to have the results in a very quick time, and tests that are fully automated and can be used in many different labs. So the widely availability of this test in different labs is very important. So nowadays, in the acute phase of TTP, the standard of treatment is represented by plasma exchange and steroid, but discussion about sparing of steroid treatment and plasma exchange is ongoing, and we are talking about using caplacizumab together with rituximab in the acute phase setting. And in the next future, also recombinant ADAMTS13 will be available for treating the acute phase. And regarding the chronic phase treatment, we should consider rituximab maintenance. So not only the induction of ADAMTS13 response in patients at high risk of relapse, but after achieving another response, we should consider in patients with many relapses in their life to go ahead with the rituximab maintenance, for example, every 6 months, as we do in other immunological diseases. And also long-term therapy with azathioprine or cyclosporine A should be considered in this kind of patients. So this was my last slide, and thank you again, Professor Agarwal, for the invitation, and I'm here to answer your questions, if any. Thank you.
Thank you so much, Dr. Marco Capecchi, for that wonderful lecture and updating us again. This was wonderful listening to you. So many concepts got cleared. We'll just give you a rest for 2-3 minutes and sort out the quiz that we had put to the PG students, and then come back to you for the question answer session. Just about 2 to 3 minutes. I'll just share my screen to answer that quiz. Okay. So the quiz that was asked this morning related to finding the etiology of a febrile illness by bone marrow biopsy. You were given the clinical profile of a young boy who has congenital neutropenia, Postman syndrome. He got admitted with a illness which was treated as infection, and a bone marrow was done to find the cause of thrombocytopenia, and that was the bone marrow. And the diagnosis was made on the presence of these structures that you see in the center. And I think it's not difficult for a hematologist or a hematopathologist to appreciate that these are hyphae. And if you look at these hyphae are narrow. Also, these hyphae are septate, and these hyphae are branching at narrow angle. So hyphae, which are not very broad, which are septate, and which are branching at narrow angle. And you can see a large number of them in the center of it, few scattered over here. And that was the silver stain, showing you again those hyphae, and you can appreciate their narrow angle branching. Now, this was aspergillosis. In aspergillosis, the septation is there, as you see the septi, and there is a acute angle branching. Okay, so acute angle branching and septate hyphae. As against this, if you say mucormycosis, then these are non-septate fungi. Okay, if you look at these hyphae, these are non-septate and they are broad, and the branching is extremely irregular. And this is a book picture. Aspergillosis narrow, mucor is broad. Aspergillosis is septate, mucor is not septate. Aspergillosis shows branching at about 45 degrees and it's regular. Same angle, same angle, same angle. Well, this can be quite erratic. So that was our patient. Narrow, septate, branching at acute angle. And this is a mucor, non-septate, broad, branching very irregularly at different angles. That's another mucor, non-septate, broad, branching at different angles. So in our patient, there was cluster of fungal hyphae branching at about 45 degrees, as you see over here. The organism was more clearly visualized by the silver stain, and this morphology was consistent with what? Invasive aspergillosis. We got various kind of answers. Large number of you have answered mucormycosis. Some of you have answered histoplasmosis. Others have answered aspergillosis. This is histoplasmosis. So this was nowhere closer to what we had shown you. We got 4 correct answers. The second, third, and fourth are these. Dr. Krishnaratnam Kannan, Dr. Mayat Marier Shu, and Dr. Sumit Mirk gave 2 answers, and the second answer was correct, and this is Sumit Mirk. The fastest finger fast was Dr. Pooja Prasad. I hope her profile and picture is correct. This is from our records. She's Assistant Professor, Department of Hematology at VMMC, Safdarjung Hospital, New Delhi. So congratulations, Dr. Pooja Prasad. Send us your details and we'll transfer the winning amount to you. Thank you so much. I'll stop sharing here and we will now go to the question answer session with Dr. Marco. We will be using raise hand sign. So here Dr. Chandrakala has raised her hand. Go ahead, Dr. Chandrakala.
Thank you, sir, for a wonderful lecture. This is a real case scenario. At present, we have a lady who is 25 years old. And in the first pregnancy, we diagnosed as congenital TTP, compound heterozygous mutation. Now she is 3 months pregnant. She's 3 months pregnant. Her platelet count has dropped to 1 lakh. It used to be 1.5 and her LDH is high. Her ADAM13 levels is nil. So first is IFD, second pregnancy, platelet count is dropping, congenital TTP. How should we manage her now? Platelet count is 1 lakh. We started plasma infusion. What's the role of aspirin? How frequently we should give a plasma infusion? Is there any role of low molecular heparin in this patient?
Okay, so if I have understood well your question, it is a congenital TTP, right? So in the acute, if the patient has now acute TTP, the plasma infusion should be done on a daily basis till you resolve the acute phase. So of course, it's a challenging treatment during pregnancy, always, for sure with congenital and also in acquired TTP. After, which is the month of the pregnancy, just to have more.
Which month of pregnancy, Chandra?
Yeah.
She is 3 months pregnant, 12 weeks.
Okay, sorry. So it's more challenging, of course, because we have more months facing us. So you should resolve the acute phase of TTP with plasma every day. And you should consider also high volume of plasma. Usually we use 15 to 20 mils every day, but you can consider also 30 mils per kilo every day. And I suggest after resolving the acute phase to go ahead with plasma for supplementation for all the subsequent pregnancy, because the risk of another relapse during the next months will be very high. So it's very difficult to tell you how often to go ahead with prophylaxis, and you should monitor closely the patient with, of course, not with ADAMS 13 because it will not be useful at all, but with the platelet count, and try to take the platelet count above 100,000. This is my suggestion, but of course it's very tricky to manage this kind of patients for everybody.
Thank you, sir.
Thank you, Dr. Chandrakala. We'll take one question from the audience. Dr. Pujita Reddy wants to know role of bortezomib in the management of TTP.
Okay, so nowadays bortezomib is not considered as the standard treatment. There are reports of the use of bortezomib in some cases. We have used bortezomib in a few cases also at our center, but remember, I suggest to use bortezomib only in patients in which it's not possible to obtain a remission with all the other treatments. So first of all, plasma exchange and steroids. Then you go ahead, if possible, you also add caplacizumab. As a second treatment line, you should consider rituximab. And I also suggest to have a sort of pit stop at some point when your patient doesn't respond to at least two line of immunosuppressants, so steroids and rituximab, especially if it is the first episode of acute TTP, because you should consider that the diagnosis has not been properly done. So sometimes we have patients with high titers of anti-ADAMS 13 and reports of the fact that even patients with anti-ADAMS 13 antibodies can have congenital TTP does exist. So if the patient doesn't respond to multiple lines of immunosuppressant, take into account the possibility of a congenital TTP, even if anti-ADAMS 13 antibodies are present at high titer. If you confirm the diagnosis of acquired TTP, you go ahead with other immunosuppressant regimens. After using rituximab, I suggest to try to interfere with the immune system on the other part of the immune system. So with rituximab, we affect the B cells. Maybe at this point it's better to try to affect the T cell system. So using maybe cyclosporin A and azathioprine or mycophenolate, which are all drugs that are being reported to be useful in these patients. And I think that bortezomib should be used as one of the last treatment choices.
Thank you so much, Dr. Marco. Dr. Sanjeevan, your question.
Thank you, Dr. Marco. That was a fantastic presentation. In fact, very closely relating to what Dr. Pujita had just asked, recently, just about 3 months ago, unfortunately, I lost a 15-year-old young girl to acute TTP, And exactly, we were following the algorithm which you had suggested. So in a way, it confirms, that we started with Plex on a daily basis. We added methylprednisolone on day 3, including a pulse methylprednisolone for 5 days, then 1 milligram. Did not respond, went on to rituximab, added bortezomib. Of course, I didn't add cyclosporine. Keplacizumab is not available in our country. So, but in spite of all these things, eventually she died of acute cerebral hemorrhage. As you had mentioned, it is very rare, but then on day 28, she developed. So my query anyway is, because of the diagnostic challenges we faced in this child, you had yourself pointed out that the functional assays are difficult to perform, technically more challenging, and not available everywhere. Same problem here. So IgG antibodies, which sounds that it's a very simple thing, have we been able to develop any cutoffs, say some quantitative levels, which will be more easy to use as a diagnostics? Because 95 to 98%, you had yourself mentioned, it will be acquired. So antibodies should be present. So why don't we use that in a diagnostic algorithm rather than getting a much more challenging functional assay? Thank you.
Yeah, thank you for the question. Is a good point, of course, but the problem is that antibodies, anti-Adams 13 antibodies, are not always present in acquired TTP patients. So in most of the patients with acquired TTP, you can find anti-Adams 13 antibodies, but as you have seen, many different tests for antibodies does exist. Usually we detect IgG, anti-Adams 13, but consider that in some cases you can have other kind of antibodies, such as IgM, you can have immunocomplexes, you can have really different kind of antibodies. So the test for detecting antibodies cannot be suitable to be sure of a diagnosis of TTP. That's why still today the functional test for Adams 13 is mandatory to make a proper diagnosis. And given this data that I told you, I don't think that anti-Adams 13 antibodies can be used to rule out a diagnosis of TTP. So unfortunately, we need to rely on the functional tests, but luckily the new test that I showed you is now available. For example, in our lab, we are in the phase of substitution of the previous test with the new one, which is really it's really a very easy test to perform. And while, for example, in the past when I had to face a TTP patient during weekend, that of course it's a big issue, or at night, I needed to call my biology, my specialized biology, to do the test, because not all of them are able to do the test, because it's a very tricky one with many variables to take into account, even from the technical point of view. But now every biologist in the lab can perform the test, because it's just an automated one. So I think that this will be the future also to help even smaller hospitals to make a proper diagnosis very quickly.
I think this ACL AccuStar is going to make all the difference.
Yeah, great.
Thank you, Sanjeevan. We'll take one more question from the audience, and that is related to how do you time plasmapheresis and rituximab infusion? What interval?
Okay, so when you have a patient with acute phase and you need to also infuse rituximab because the patient doesn't respond, so you have a refractoriness to treatment, so after 7 packs you don't have a response, you should consider to introduce rituximab. The problem with rituximab infusion is, while performing packs, is that rituximab can be taken out of the plasma with the plasma exchange procedure. So we suggest to perform the plasma exchange in the morning and soon after the plasma exchange is finished, the patient starts rituximab. That will take over 4 to 6 hours, depending on the patient condition. And so the next plasma exchange will be the next morning. So at least 4 hours after the end of the infusion of rituximab, before the next PEX will last. So this is the minimum amount of time to do the other PEX after rituximab. Of course, if not possible, you will do it earlier, but remember that you will lose some of the effect of rituximab.
Thank you. Dr. Amrita, your question.
Thank you so much, sir, Dr. M.B. Agarwal, sir, and thank you so much, Dr. Marco. That was a wonderful presentation. So just a very few basic questions I had. One is, since we use very high volume of plasma, so do you have any specificities to the plasma that is being used for exchange? By which I mean, do we use a solvent detergent plasma or any other specific specificities regarding the plasma?
Okay, so if I've understood well the question, you are asking about the type of plasma to be used. Okay.
Yes.
Okay, so we don't suggest to use any specific kind of plasma. You can use the normal fresh frozen plasma by donors. You can change to other kind of plasma if the patient will develop some reactions to the plasma. So in this setting, but as all other settings, when you develop a transfusion reaction to normal plasma, you can consider other kind of plasma that are more inactivated and more safe to reduce infusion reactions. So no specific recommendations for TTP, but just the normal management of plasma infusion as in other settings.
Right. Well, the second question was the role of antiplatelets in a patient with TTP, say a patient who has achieved a platelet count of more than 50,000 and maintaining it there. So do you routinely give antiplatelets, aspirin, or in certain settings?
You mean antiplatelet drugs?
Yes.
Okay, so in TTP, it's not necessary to give antiplatelet drugs just for the TTP, but consider that many TTP patients can present at presentation with neurological signs, and sometimes these neurological signs can be due to ischemic lesions in the brain. Usually, these lesions are very small because the disease affects the small vessels, so you don't find at CT scan, basal CT scan, you don't find big ischemic lesions, but sometimes in patients with severe neurological symptoms, you can find also ischemic lesions, and these are the only patients in which antiplatelet drugs can be considered for secondary prophylaxis of ischemia. Concerning this point, it's a very important point, so thank you for your question, because nowadays we have, at least in our country, the possibility to use caplacizumab. And caplacizumab, even though the phase 2 and 3 studies didn't show an increased risk of grade 3 and 4 bleeding events, if you caplacizumab, because of its mechanism of action, reduces platelet aggregation. So if you give the patient another antiplatelet drug or even heparin for thrombosis prophylaxis, you can increase a lot the risk of bleeding. So we should be very careful in using antiplatelet drugs or antithrombotic prophylaxis in patients while on caplacizumab in the first days.
Thank you. Yeah, go ahead.
So I just had another couple of questions, if I may.
Please go ahead.
Okay, so the third thing is obviously we have to look for alternative management in cases of chronic TTP not responding to rituximab or the standard plasma exchange. So we may consider cyclosporin or tacrolimus, and how well, when would you recommend really starting with therapies? And I always had this little doubt in my mind regarding tacrolimus, because we all know very well that this can cause tacrolimus itself can cause microangiopathy, TMA. So when would you give tacrolimus, if at all you do give? And then how do you even differentiate whether the patient is not responding or the patient is developing a TMA?
Okay, so this is a very tricky question again, because guidelines doesn't consider this point because we have no evidence in this setting. So it's just a sharing of our experience with you. So when rituximab fails to have a response, you should consider other immunosuppressants. Between also all the immunosuppressants that we have available, it's true that cyclosporine A and tacrolimus can be associated with the risk of relapse, because as you mentioned, these two drugs are related to drug-related thrombotic microangiopathies. So the risk is to elicit an onset of another kind of TMA in the patients that already had TTP. But no reports of cyclosporine associated TMA has been reported in patients with TTP treated with cyclosporine. So these are the evidence. So we prefer to use cyclosporine just because after using rituximab and after affecting the B lymphocytes, we want to affect the other part of the immune system. So that's why our decision to choose cyclosporine after rituximab. But all the other immunosuppressants can be used, and we use very often azathioprine, for example. And I can anticipate that we are evaluating the data of the use of azathioprine in our cohort of patients, and preliminary results are very good on its effect on long-term management of this kind of patients. And in some patients, we also use mycophenolate. I can say that we have never used tacrolimus in our experience, so I cannot give you any idea of the use of tacrolimus in this setting. And to my knowledge, no reports are on that, but maybe there are, and I don't know.
So one just final last very basic question. Like we all know, these TTP patients are pretty much sick, and most of them are admitted in the critical care settings. So sometimes it is difficult to differentiate them from other microangiopathic hemolytic anemias. And obviously an RMTS assay does take time, and not necessary that a patient will present with all 5 pentat that we know. So when do you clinically decide whether to start a patient on plasma exchange or just other conservative lines of management?
Okay, so when you suspect a TMA, you consider as I told you, the pretest probability of having severe deficiency of ADAMTS 13, so the plasmic score or the French score, and these two scores are really highly reliable. So if the score is high, you start immediately with plasma exchange. And even if you are not facing TTP, but another kind of TMA, you should start again plasma exchange, because even if in other kind of TMAs, the plasma exchange is not the mainstay of treatment, it is not, you are not going to harm the patient. So start immediately with PEX, wait for the ADAMTS 13 levels results that you need to have in 24 hours. And consider that when you suspect TTP, you can also start caplacizumab, even if you don't have the result of ADAMTS 13. But it's mandatory to have the results at least in 24 hours. So you are also, you can also use caplacizumab without a diagnosis for the first 24 hours. And this is very important because it stresses the importance of starting treatment very quickly.
Thank you very much for answering my questions. Thank you. Appreciate it.
Thank you. One question from the audience again. Can direct Coombs test be positive in TTP?
Okay, I went very quickly on the first part of the presentation because I wanted to focus on the testing this time. But TTP and all the thrombotic microangiopathies are defined as having a direct Coombs test negative. So direct Coombs test should be negative. If direct Coombs test is positive, you should take into account other diagnoses, and especially autoimmune hemolytic anemia, of course. And if you have to, at the same time, an hemolytic anemia together with reduced platelet count, you should consider the diagnosis of Evans syndrome. So no direct Coombs test positive in TMAs.
There's a related question, so I'll put it to you. Can TTP be secondary to systemic collagen vascular diseases characterized by ANA positivity, CCP positivity, low C3, C4, etc.?
So TTP can be is not second. We cannot say that TTP is secondary to other diseases, but acquired TTP is an autoimmune disease, so it can be associated with other autoimmune diseases, and we can see that these patients usually have other autoimmune diseases that are associated. In most cases, we find an autoimmune thyroiditis, which is very often present in these patients, but in some other cases, we can find other autoimmune diseases, and especially lupus erythematosus systemicus, also rheumatoid arthritis. So all the autoimmune diseases can be associated to TTP, but this is not. We cannot consider it as secondary to other autoimmune diseases.
Thank you. Dr. Ria, your question. Unmute yourself, Ria.
Yeah, that was an excellent talk, Dr. Marco. I just have one question. When you spoke of chronic TTP maintenance therapy, rituximab, how frequently would you give it, and what would be the dosing regimen? Chronic TTP, yeah.
Okay, thank you for the question, because the answer is that anybody knows. It's just a new topic. That's why it was in my last slide. Unfortunately, some patients have many relapses during life. So what we do in our clinical practice is to follow these patients with Adams 13 testing after the acute phase TTP has resolved, and we do it every 3 months in the first year, and then less frequently in the subsequent years. When the patient has a drop in its Adams 13 levels under 20, and it is confirmed on a second time, we decide to start preventive rituximab, and we perform 4 to 6 weeks of rituximab. Then we start to follow up the patient again. But if the patient has another Adams 13 relapse, we need to do another preemptive treatment, maybe with rituximab, and how we choose if using immediately rituximab or another immunosuppressant. We consider the time that the patient has remained on response after the last rituximab. The median time of response to rituximab is 18 months, and if the patient has relapsed too quickly, we decide to switch to another drug because rituximab doesn't give us a long response. But if the patient, for example, responds to preemptive treatment with rituximab 2 to 3 times for a long period of time, after 3 to 4 relapses, of course, there are no guidelines, so it's our choice together with patients. We can start, I think, to consider a maintenance with rituximab. Nobody knows which schedule should be considered. What we are starting to do at our center is to perform rituximab infusion every 6 months. Of course, if the patient has achieved a good response after the induction with rituximab, as is already done for many years in rheumatoid arthritis, for example. So we think that, but it's just our our considerations that rituximab every 6 months should be increase the time of treatment for these patients.
So when you give it 6 monthly, it's again the weekly schedule dosing of 375 mg per meter square. The 4 doses completely.
Yes.
Fine.
Yeah. But again, no guidelines on that. It's just our consideration.
Thank you so much. Yeah.
Thank you, Dr. Ria. We'll take one more question from the audience. What about the role of cyclophosphamide in TTP?
Okay, also cyclophosphamide can be used again as all the other immunosuppressants. I didn't mention it because it's one of the less used immunosuppressant drug, but sometimes when you have finished all the immunosuppressant that you have available, you can consider also cyclophosphamide. Which doses of cyclophosphamide can be used? We can consider the low dose that sometimes we also use in acquired hemophilia A, or in very severe patients, we can consider one infusion at higher doses like in hematological malignancies. But again, data on this treatment are too scarce to give advice and suggestions.
Thank you. Dr. Abhishek Dudatra.
Thank you, sir. Thank you, Dr. Marco, for a very informative talk. My question again is on replacement fluid for plasma exchange. So although guidelines are saying to use 100% plasma, but many centers here do practice using additional fluids like normal saline or albumin in ratio of maybe 30 to 40% to plasma, and patients seem to respond similarly. So do you have any experience with this, or is there any data comparing 100% plasma versus less than 100% with addition of saline or albumin?
Okay, we don't use we use 100% of plasma. And in the guidelines of TTP, full plasma infusion is advised. But I have no experience in what we are saying. I imagine that, of course, if we have talked about 1 volume plasma to be exchanged, and this is the guidelines that should be followed. And if you dilute the plasma with some other buffers, you will reduce the amount of plasma that you give to your patient. So when you decide the amount of plasma that you give, you need to use a calculation. There is a formula to evaluate the plasma volume of the patient based on the hematocrit and the weight of the patient, and that's how you decide which is the volume of plasma that you should infuse. So I think that it's important to infuse that amount of plasma. Then if you want to dilute it because of some issues, you can do it, but the important thing is to give the patient the correct amount of plasma that he needs.
Thank you.
Thank you, Abhishek. Dr. Satish.
Thank you, sir. Thank you, Dr. Marco, for that excellent presentation. I have several questions. Firstly, regarding the plasma, you have told in detail that it has to be 100% plasma. Some of the centers do not have this centrifugation devices we use in the blood bank. So can we use this membrane based what they use in hemodialysis machine? Is there a difference using the normal centrifugation technique in blood banks versus the hemodialysis machine membrane separator for plasmapheresis?
I think that I'm not the correct person to answer this question, because I explain you how it works in our center. In our center, the roles are very different people have different roles. So in our center, we have a team of people that manage the procedure itself. So I'm part of the clinicians that manage the patient and that give the indication for treatment, but I don't manage specifically the plasma exchange. So I don't want to give you information that are not very.
Sorry for that question. So the second,
correct.
The second thing is in acute immune TTP. once we start the treatment, you said wait for 7 days, start steroids, start plaques, wait for 7 days, and then start rituximab. Whereas the ISTH guidelines say to start rituximab immediately. So I wanted to know, see, initially we were waiting for 7 days, 10 days, and then starting rituximab. I personally, in the last 2 years, whichever cases I have seen of TTP, maybe on the 3rd day or earlier if possible, of course, following all the guidelines and precautions when to give rituximab. I somehow feel that if we start rituximab early, they respond well and we are able to wean off the plasmapheresis. Should we really wait for 7 days of plasmapheresis and then start rituximab, or can we start rituximab early?
Yeah, I agree with this point. In fact, as you mentioned, the ISTH guidelines changed, and also our national guidelines changed. We prefer not to use rituximab in all patients because most of them, and especially now that we have cabazitaxel available, respond very quickly. And consider that most patients nowadays need to do the plasma exchange only for 2, 3 to 4 days. So consider that after starting cabazitaxel, these patients have a response in platelet terms after the second or even the 3rd or even the 2nd day after starting treatment. So I think that maybe using rituximab immediately is not useful in most patients. I agree with the fact that 7 days maybe it's too much, but it's the definition of exacerbation. So I think that you should consider it. What we do is considering 5 days instead of 7. And
it is not available in India.
So yeah, I understand. Okay, so I think that in this case you should try to stratify the risk of the patient at first as best as you can. So consider the cardiac involvement and the brain involvement. And the cardiac involvement, it's easy to consider because you just consider the electrocardiographic changes during the first hours, the eye troponin levels. So I think that these patients may benefit in absence of cabazitaxel over more strong treatment at onset.
Right. Thank you. Sir, can I ask a couple of more questions?
Sir, can I try and answer Dr. Satish Kumar's technical point just he had mentioned?
Go ahead, Sanjay.
Okay, I think Dr. Satish wanted to know about, because this is a problem which we faced about whether the dialysis machine based the membrane column which they use and the standard centrifugation based plasma exchange machines which we use. So firstly, because in that patient which I mentioned in which we lost this girl, we had this problem. Our machine went off-road, the centrifugation base. So we did use the dialysis, and when we did our study, they are firstly equivalent. The only thing is, in case of a hemodynamic compromise, just like in dialysis, that will be a challenge. But whereas the efficacy of removing the antibodies and of course replacing it, is both of them are equivalent. Whichever you have, you can go ahead with that.
Okay, thank you so much, Dr. Kalna.
Thank you. Satish, can we come back to you?
Sure, sir.
Discussants have said that we should take one question at a time per person.
Sure, sir. Sure, sir.
We'll come back to you. I think Dr. Marco is with us for some time. So, Dr. Rima.
Good afternoon, sir. Sir, is there any role of using Adams 13 level in transplant-associated TMAs?
Yes, it's important to rule out TTP. So when you suspect a TMA, even if TTP after hematopoietic stem cell transplant is very rare, but it does exist, the first things to do is to exclude TTP because it has a specific treatment. Then when ruled out it, you can consider the management of transplant-associated TMA, which is different. And as you may know, maybe better than me, it's more challenging than in TTP because unfortunately nowadays we don't have drugs for this specific setting. Even though there is a drug that is under investigation, specifically in the pediatric setting, and that will be available in the future even for transplant-associated TMA. So it's important to dose Adams 13 to rule out TTP in every setting of a suspicion of TMA.
Thank you, sir.
Dr. Gunjan.
Thank you, sir, for an excellent talk. My question is related to the long-term complication of stroke. So how often you see this complication in patients, and how should we monitor, and is there any specific group of patients in which we should look for these complications?
Yeah, so the risk of stroke is especially in the acute phase. There is no risk in patients in remission, because with normal levels of ADAMTS13, the pathophysiological mechanism of the disease doesn't occur. But stroke is not often at presentation of acute phase TTP, but you should consider stroke in patients with very severe neurological signs. And there are some studies on the association of ADAMTS13 levels and the risk of stroke, and also the risk of cardiac ischemia in the long term, but no data are available yet on this topic. Anyway, the role of ADAMTS13 in this setting is being investigated very deeply nowadays.
Thank you, sir.
Thank you. Dr. Akshay Mandaloi.
Thank you, Agrawal sir, for giving me this opportunity, and thank you, Marco sir, for a wonderful and informative lecture. Most of my queries have already been covered. Only doubt I am having is in a patient who was who have had first episode of TTP and now is asymptomatic, but he has not received rituximab before. Is there any role of rituximab now?
You should check the ADAMTS13 levels. So if the patient has recovered well from the acute TTP phase, and I mean that she has normal levels of ADAMTS13, you don't need to do any infusion of rituximab, even if she has high titer of antibodies, because you should consider the ADAMTS13 levels. So the suggestion in the chronic phase is just to follow up the patient with repeated ADAMTS13 determination. And if this goes down and for two consecutive times, it's under 20%, you can consider at that point treatment with rituximab.
Thank you, sir.
Thank you. Dr. Aditi Jain.
Thank you, Dr. Marco, for a really good lecture. I actually have a patient who has had 2 episodes of self-limiting TTP. Both times she didn't receive any specific treatment. It went undiagnosed. In the second episode, when she came to us, we did send the ADAMTS13 level, and it was 8%. Antibody test was not available, but we did a gene sequencing, and she was negative for congenital TTP. She, however, didn't take any treatment, and she again recovered. And when she came back to us in a few weeks, her CBC, LDH were all completely normal. How do I treat a patient like this? Both her episodes were self-limiting, and it's probably acquired because congenital TTP was ruled out. So do I actively treat her with something, or do I wait for another episode? I mean, how should I follow up this patient? She's come around 3 months since the last episode, and her CBC and LDH are fine right now. She's asymptomatic.
Okay, so she has had 2 not properly acute phase of TTP because she was asymptomatic every time, but she had, you mean the complete blood count features of TTP?
No, she was symptomatic. She had neurological signs, and she was sick. She was admitted but given supportive care in a small hospital in her village. She was not diagnosed as TTP and given specific therapy for TTP. And she recovered with transfusions, probably blood and platelets, and no steroids, no immunosuppressants were given. But both times she recovered without any specific TTP treatment.
Okay, so I think that this patient, it's a high risk of relapse, of course, because she has had 2 episodes of the acute phase, even though not with overt symptoms, but the risk of relapse is very high, and still ADAMTS13 levels are less than 10%, if I have understood well.
So we don't have a follow-up report because she can't afford it. During the episode, it was less than 10%, but she can't afford a follow-up report.
It's highly likely that the ADAMTS13 levels is still low, because if you don't do a treatment, it's very unlikely that ADAMTS13 goes back to normal values. So I suggest you to try to dose ADAMS 13 to confirm the fact that it's low, and I think that this patient deserves treatment, and I mean preemptive treatment, not treatment of the acute phase, of course, but the preemptive treatment, because the risk of relapse is very high. And if a patient has relapsed once with neurological signs, usually the subsequent relapse occur usually with the same kind of symptoms. So the risk of neurological signs and neurological impairment in the long term is very high. So I think is better to treat preemptively the patient.
Okay, so one more thing, is it quite common to find these self-limited mild kind of presentations which resolve on their own in TTP?
Not at all. Not at all. That's why I asked you again if I have understood properly, because usually it's not self-limiting, but it's a system that when it starts goes further, and if you don't treat the patient, as I showed you, firstly the mortality rate is very high. So it's uncommon, but my question would have been, did you perform the genetic analysis? But you answered before a question, so you did all the diagnostic algorithm properly, so you are sure that it's an acquired TTP. So I think that you need to treat the patient preemptively.
So then I should give steroids and rituximab, or wait for
No,
rituximab?
if we are in the chronic phase, so not acute phase now. So you just need to use rituximab to prevent another relapse, without any steroids.
Okay, thank you so much, sir.
So we'll take one question from Satish, and then Chandrakala, and then back to Satish.
Thank you, sir. So you mentioned in chronic TTP, you mentioned to monitor the first year following the acute episode, to monitor the ADAMS 13 every 3 months. What about in the acute phase? Once we luckily we have ADAMS 13 available here and they get the report within 24 hours. How frequently do we monitor in the acute phase?
Okay, it depends. There is no guidelines on that. I mean, I think that it's not necessary if you need to spare the test to when it's really necessary. I think that you should first of all, in the first days, to monitor just the blood count, because the blood count and the biochemistry, so the LDH, the hemolysis index, and the clinical features of the patient. So the first endpoint of treatment is the resolution of clinical symptoms, the normalization of hemolysis index, and normalization of the complete blood count. So for the first days, you can just monitor these parameters. When you have achieved a clinical response and a complete hematological response, you can stop the plasma exchange. And at this point is more challenging, because you need at this point to monitor the ADAMS 13, because based on ADAMS 13 levels, you will decide how to go further with treatment. So if you need to start rituximab or not. Usually these patients respond in terms of ADAMS 13 very quickly, in 1 to 2 weeks. So I suggest after stopping of plasma exchange to monitor again ADAMS 13 at least 1 week after. So at that point, you can have an idea of how this patient is going on. At our center, we check ADAMS 13 at least weekly for the first month. And if the patient achieves a good response, then we go ahead with ADAMS 13 monitoring for each month, while the patient is on treatment with steroids. And consider that steroids is used at full dosage for 1 month, and then you will go with a very slow tapering in another 1.5 months. When you stop the steroid, it is another critical point, because you can lose the response again. So I suggest you to check again the ADAMS 13 1 week after the stop of steroids, and if possible at 1 month after. And if the patient is well, the ADAMS 13 levels are normal, you can start with the protocol every 3 months in the first year after treatment. That's what we do at our center.
Got it. Thank you so much.
Thank you. Dr. Chandrakala.
Sir, you mentioned about the Grifols Kuwait factor. It's available with us. How do we use it, and which conditions we use it? Actually, is it which conditions should we use it?
Okay, we actually, I just mentioned it. It was on the slide, but I didn't even mention because we never use it. But it's just to know that there is this factor rate derivative that contains an amount of Adams 13. It's not that high amount, so it's better to treat patient with fresh frozen plasma. It was just to be mentioned because to underline the fact that the effect of plasma is just to give patient with congenital TTP the Adams 13, but when we will have available the recombinant Adams 13, of course, we will not talk anymore about this factor rate concentrate. And consider that you will give to this patient also high levels of factor rate, and you can have also von Willebrand factor, so you can the patient could also, you can also activate the coagulation, and you don't want this in acute phase TTP. So I wouldn't recommend to use this concentrate.
Thank you. Satish, back to you.
Thank you, sir. Dr. Marco, the last thing is about pregnancy and TTP. So two situations. First situation, a married girl, we have a patient, similar patient, who just got married, developed immune TTP, and she responded. We had to give rituximab. She responded very well. After a couple of years, she's keen on pregnancy now. So we have monitored the Adams 13. It came around 20 to 30%. I don't remember exactly. So we have given again Ritix for 4 weeks, weekly for 4 weeks, and told her to wait for 6 months. So how do you monitor such people, and what do you counsel them regarding the risk of relapse in pregnancy?
Okay, we monitored the patient exactly as you did. So we try to perform of course, the most important thing is to talk with the patient because to have a second pregnancy after the first one with the TTP, it's really challenging. So the patient should be advised well about the risk for her and for the newborn. And so after this phase, we need to tell the mother that she will need to come to the hospital at least once a month, and we monitored Adams 13 every month as you did. So I fully agree with the management that you followed for your patient.
What do you keep the threshold to give rituximab? I believe rituximab is safe only in the first trimester. We avoid it in second and third trimester. So what threshold do you keep to give rituximab?
Yeah, I think that if the patient, I think that I will take the threshold of 20, because if the patient, it's true that less than 10% is already acute phase, but if you go below 20%, the risk of relapse is too high, and it's better to start immediately with rituximab.
Great. Thank you so much, Dr. Marco. Thank you so much for patiently answering all our questions.
Thank you. 1 or 2 questions from the audience. Is there any association between TTP, ADAMTS deficiency, and COVID vaccine-induced thrombosis?
Okay, so it's a very actual question, of course, and even though in the literature some reports have associated TTP onset or relapse with the COVID-19 vaccination, and especially with the mRNA-based vaccination, I can say, even if it's not published yet, but we are writing the paper right now, that we performed a prospective study on these patients. So in our cohort of patients with TTP, we vaccinated all these patients with mRNA vaccines, and we evaluated Adams 13 before the first dose, after the first and the second dose, and we didn't find any relapse, any clinical relapse, and also any Adams 13 relapse. The cohort is not that big, but considering that the TTP is rare, we enrolled 50 patients, so I think that it's a considerable number of patients considering the rarity of the TTP. So not yet published, we are still working on that, but the preliminary analysis showed that no clinical relapse and no Adams 13 relapse. And I want to highlight that COVID-19 disease, on the other side, is a disease that can precipitate the occurrence of acute phase TTP, and in this case the risk is so high that prevent the disease with vaccination is very important for these patients.
Dr. Marco, there's one last question which is not exactly on TTP. The question is about management of atypical HUS. Do you want to take it?
Sure. So atypical HUS, I just mentioned it in one of the first slides. It can be congenital or acquired, as I told you, and it's completely different pathophysiological mechanism, and it's characterized by inactivation and overactivation of the complement system. So very quickly, the treatment of this patient, other than supportive treatment, because these patients present with renal insufficiency, which is very severe compared to the renal insufficiency that we can see in TTP patients. So it's very important to do a good supportive treatment, but the mainstay of treatment is represented by eculizumab, which targets specifically the complement system. So this is a completely different treatment for TTP, but it's important to recognize also HUS because it has a specific treatment like TTP.
Thank you, Dr. Marco. I don't see any other raised hand sign and no question in the question box. Is there anything anybody wants to discuss with Dr. Marco? If none, then thank you so much, Dr. Marco, for sparing your Sunday morning for us. You gave a great talk and QA session last time, and even more important, extensive discussion this time. We had a feeling that there is a place to have this lecture again and discussion, and that was fully justified by so many questions from very, very senior faculty present over here from India. So thank you so much. We are grateful.
Thank you very much for the invitation. It's been a pleasure to discuss this topic with you.
Thank you. And the official vote of thanks from Dr. Rahul Patel, please.
So thank you very much, sir, for this nice talk. And we really grateful to Dr. Agarwal for giving us this wonderful opportunity to participate in this meeting, and especially thank to Dr. Marco for this talk, and have a nice day. Thank you very much, sir.
Bye-bye. Bye to everybody. Thank you.